With this, I would like to invite my best workhorse, and without him, my surgery journey is incomplete. That is Dr. Burhanul Haq. Though he irritates me to the most, but I can't do any work without him.
Thank you, Dr. Atif, for your kind words. Welcome, everyone. So, the topic given to me is evaluation before revisional bariatric surgery. I'll try to stick to the time. So, there are three things which fall in the ambit of revisional surgery. One of them is conversion, where you change one type of procedure to another type. Another one is correction, where you just improve upon the anatomy of that procedure. And the third one is reversal, where you altogether undo the procedure that has been done and restore the original anatomy of the patient. So we will tackle them one by one. Indications for conversion are ineffective weight loss. As Dr. Atif was saying, failure, and now the fancy term for the failure is suboptimal clinical response. So if the after the index operation, patient failed to achieve more than 20% of total weight loss, it is called suboptimal clinical response. And then if patient fails to have a considerable improvement in the comorbidities, that can also be an indication for conversion. Weight regain, perhaps another fancy word for this is now being used is weight recurrence. So if the weight recurrence is more than 30% of maximum weight loss, or if there is recurrence or worsening of the obesity related complications, that can be an indication for conversion. Obviously, twist, stricture, GERD are also indication for conversion. So indications for correction include anatomical or mechanical failures, like if there is a dilation of sleeve, you can always go in and do a re-sleeve. If a dilation of gastric pouch, you can go and retrim it, and so on and so forth. Then there are indications for reversal, very important. So the indication for reversal include intractable and refractory nutritional and metabolic complications. So ASMBS and IFSO guidelines 2022 have more than 90% Delphi consensus on NMDT before deciding anything. And they stress that for weight regain, a minimum of 6 to 12 months conservative management should be tried. And as the OMM have been now more fashionable, this is changing the landscape of conservative management as well. So MDT should always include, but not limited to, surgeon, specialized bariatric dietitian, bariatric psychological assessment, and endocrinology input. So before treating or deciding for revision, ask yourself what is the problem at hand that you are treating. Is it weight regain? Is it suboptimal clinical response? Is it GERD? Is it obstruction, malnutrition? What previous operation was done? What does the anatomy looks like now? What are the contributing factors to the patient symptomology? And is the patient nutritionally and medically and psychologically fit for another operation? And also carefully review the plan, the procedure you are planning, will it help the patient or not? So regarding the pre-op workup, endoscopy is a must. I don't care. यार ये आउट क्यों हो रही है, बाहर से जा रही है, हाँ? लेकिन ये उससे आउट हो रही है ये, हाँ?
Please continue, Burhan.
Yeah, thank you. So endoscopy is a must, it is mandatory. Before taking any patient for revision, you must do endoscopy, and you will find ton loads of information while you're doing while you've done the endoscopy, and I assure you, you will never regret it. Same goes for upper GI fluoroscopy, should be done. There's no harm in doing that. 3D CT volumetry can selectively be done in sleeve patients if you want. CT abdomen, as Dr. Javed Raza was saying sometime in the earlier session, if there is chronic pain, if you suspect internal hernia, if there is difficult and complex anatomy, if there are chronic leaks, collections, fistulas, CT will provide you with valuable information. High resolution manometry and pH testing should be done to objectively find out the burden of reflux if there is any, and if you suspect the distal esophageal dysmotility disorder. You should take carefully the nutritional history of the patient. As Adnan was mentioning some time ago, like if a patient, what kind of a eating phenotype patient has, is if a patient is having a pattern of grazing, or if he is having or if the patient is sweet eater, and you are going inside and re-sleeving the patient, or making the sleeve tight again, it will not work in that patient. So this is the panel of labs you should always be doing before deciding upon for a revision. This is a routine panel, and as Carlos was saying, smoking is one of the big no's. So never ever take the patient for a revision unless he has quit smoking. And also, I think you were again mentioning more leaks in diabetics. So if their HbA1c is not optimized, do not take these patients for revision. Psychological and behavioral assessment, you see, you must identify the barriers before creating a more demanding physiology in a patient by revising his index operation. So obviously depression, anxiety, and all these disorders must be ruled out. See, if patient is suffering from depression and eating his or her coping mechanism, and you take that away from the patient, you are sending that patient to harm's way. Don't do that without proper psychological assessment and optimizing that patient psychologically. And also you have to realistically sit with patient and talk about the expectations of a revision as well. So this is procedure specific evaluation, and endoscopy and upper GI series should universally be done in all of these procedures, and rest you can do selectively. So if, for example, there is a 45-year-old patient, 5 years ago, sleeve gastrectomy was done, good initial weight loss. Now patient presents with reflux and weight recurrence. The knee-jerk response will be, sleeve has failed, let's take that patient and convert it into a bypass. But there can be a more systematic approach to that patient. get a upper GI endoscopy done, upper GI series, define the hiatal anatomy, define the anatomy of the sleeve, quantify if there is any reflux, rule out Barrett or esophagitis, and assess the metabolic phenotype of the patient, evaluate his or her nutrition, optimize her, and then decide for an intervention. So basically, the take home here is index operation does not decide what kind of operation you are going to give as a revision. It's the indication of the patient. So in a post RNY patient, if a patient presents to you with weight recurrence and endoscopy demonstrates markedly dilated gastrojejunostomy in ostomotic diameter, maybe that patient is more suitable for transoral outlet reduction if it is available, rather than taking that patient to theater and distalizing him or her. So sometimes a patient referred for revision are best suited for revision endoscopy or other least invasive options. I'm sorry, some part of my slide is going out of this. So decision of revision is always a matrix of risk versus benefits. So ask what exact problem the proposed operation will correct, and are the expected benefits worth the incremental surgical and nutritional risk to the patient. This is very important. So in essence, redo bariatric surgery is essentially a diagnosis before it is a reoperation. And weight recurrence is a phenotype, it's not a mechanism. And know exactly what was done before deciding what you are going to do next. Anatomy, physiology, nutrition, behavior, and medical factors must all be taken into account. MDT and patient optimization are mandatory before proceeding. So do not revise a number on a scale. Agree, Carlos? Revise a demonstrated mechanism in an optimized patient. So to conclude, never skip MDT. Anatomy will most of the time dictate what type of a second procedure you will going to give to your patient. Behavior will dictate the long-term success of the revisional surgery, and optimization will save lives, because mind it that revisional surgery carries twice the risk of complications and mortality as compared to the index operation. Thank you. So I also invite you cordially to attend our this second IBC summit, which will happen in October this year. Thank you.
Thank you so much, Burhan.